Okay, good morning everyone and welcome to this HELIConference webinar on the impact of the COVID-19 crisis on healthcare in Belgium. My name is Brecht de Vleeschouwer. I'm head of the service Health Information at Cienzano, and together with my colleague Laura van den Borre from Cienzano and VUB, it's our pleasure to be your host during today's webinar. As you all know, the COVID-19 pandemic has tested the ability of the Belgian health system to adapt to external shocks. Different approaches were taken to manage the pandemic, such as postponing care, expanding capacity, reorganizing care services, but also patients themselves responded in different ways to the crisis situation. In order to further develop a resilient health system, there's a strong need to understand the impact that the crisis has had on the Belgian healthcare system, and also how the healthcare system has recovered since. HELICON has therefore invited 4 leading experts to provide more information on the impact of the crisis in general practice, in care facilities, and in hospitals. So these people will be introduced later on. The webinar today is organized in the context of the HELICON project, which, as you can see on the next slide, is funded as part of the BELSPO BRAIN program. The project runs from 2021 to 2025 and is a collaboration between Cienzano and different Belgian universities. Overall, the project aims to generate insights on different aspects of the crisis, the social inequalities in COVID-19, but also the long-term and the indirect effects of the crisis. And in addition to generating new evidence ourselves, we also aim to provide a platform for Belgian researchers and professionals to share their insights on these 3 main topics. So that's why we are here today together for one of our HELIConference webinars. And today the focus is on the impact of COVID-19 on healthcare as one of the key indirect impacts on the crisis. On the next slide, we have the program of today's webinar. And there you see the different guest speakers that we invited today. So first we will have Margot Cloet, Managing Director at Zorgnet-Icuro, who will present on COVID-19 in Flemish care centers. Afterwards, Sarah Willems, Professor of Equity in Healthcare at Ghent University, will present on the organization of Belgian GPs during COVID. Then the third speaker will be Johan Pauwels, working in the hospital audit unit of Recife Inami, who will quantify the decline of regular medical care in Belgian hospitals during the crisis. And then finally, we have invited Pedro Facon to take the final word. Pedro is Deputy Administrator General at Recife Inami, and he will conclude our webinar by sharing his general reflections on the different presentations and on the topic at hand. Before we get started, we also have some housekeeping messages. During the webinar, we will keep your microphones switched off so that there are no unpleasant background noises. You are, of course, welcome to open your video so that our speakers know who they are talking to. After each presentation, there will be time for questions and answers. You can start writing your questions in the chat during the presentations. You can also raise your hand to take the floor. The slides and the recording of the webinar will become available via our website, brainhelicon.be, after the end of the webinar. So without further ado, I suggest we kick off our webinar with our first speaker, Margot Cloet. So Margot, feel free to start sharing your presentation. And Margot has been Managing Director at Zorgnet-Icuro for over 5 years. Zorgnet-Icuro is the umbrella organization of Flemish general hospitals, mental health initiatives, and not-for-profit residential care facilities. Margot serves on numerous governing, consultative, and advisory bodies in the welfare and healthcare sector, and she was also one of the active voices during the COVID crisis. So a very good candidate, I would say, to kick off this webinar. So Margot, please feel free to take the floor. Thank you. And you will need to unmute yourself. Yes.
Okay. Thank you, Brecht, also for organizing this webinar, even if we know that the most of us want to forget Corona as soon as possible and even don't want to think about it. I think it's important to reflect and continue to learn from the crisis and to improve our elderly care. That's the focus of my presentation today. We also have been working in hospitals, but the Flemish elderly care was very impacted in this crisis. And so I want to go back to 2020, which was a start of a very intensive period in elderly care for caregivers, but also for people who stay there. On February the 3rd, the first corona infection was detected in Belgium. On March the 10th, the first corona victim was the first corona victim in Belgium who died. And on March the 12th, a very special day, no any visit was possible in the nursing homes. That was a decision that was very hard to make and that had a very great big impact on the elderly people who are staying in the elderly care, but also on the people who work there. They didn't know what to do and how to act. On the 18th of March, we had the lockdown, and on the 18th of May, visiting, but it was restricted, was again possible. So we also made recommendations. There was a task force of elderly care homes in Flanders, but the lockdown stuck this. Did make that there was no visiting anymore possible, and we were very happy that on the 28th of December there were the first vaccinations, and the first people who got this were the people who stayed in the elderly care homes. But there was a lot of chaos in the first weeks. I often had directors on my phone crying and not knowing what to do. People died. There was a lack of oxygen shortage in the nursing home. There was a major unrest of lack of protective equipment. There was a failure of staff and search to replace them. And often we find on the political level, there was no sense of urgency in these nursing homes. There was no visibility on number of outbreaks. There was no data. There was a demand for oxygen becoming increasingly urgent. A demand for testing capacity initially remains unanswered. Tests who finally were supplied come with wrong leaflets. There was a lack of helping hands. We were very happy that the hospitals and also caregivers out of the home care offer help spontaneously. There were digital training moments for nursing actions because they need education to do some acts. And there was an establishment of all kinds of systems in society, but also from colleagues active in the care. From the 20th April to the 18th of May, the calm gradually returns. I say gradually because until the end, it has been very difficult in those nursing homes. And so, what did we learn about it? What we have seen is a strong and dynamic elderly care, but also a lot of problems we suffer for years. A lack of staff, a lack of finance. That were the problems. But what did we learn? What is the way to go? It's easily speaking. Nursing homes workforce planning must cover three crucial elements. Ensuring that there is a sufficient staff for corresponding care needs of the residents. Ensuring that all nursing home staffs have skills. And in this time, it's not easy. They need to care for the residents. They need to know how they had to act about oxygen, how to put the people into the right bed or into the right group, the one who are infected, the one who are not infected, and so on. And we should ensure that the staff is cared for that there is cared for the staff on the mentally and emotional level. And that also was a problem. The structures were enabled to action, but also they sometimes hinder action. And the trick is to design the structure of residential care in such a way that care workers are maximized in their ability to provide good care with a little hindrance as possible, skills, architecture, and so on. Architecture is a really important aspect in it. We should commit to age-friendly homes and further on diversify our housing offer. What we saw is that when we lived in small groups, there was less infection, and that in big institutions, more people died. There was more mortality. So that's something we learned, and that also was put into that we use now to develop further on the design of elderly care. What we also have seen is that we live in a culture where there is a lack of appreciation of older people. A structural approach to ageism, to any form of age discrimination, should be developed. And also, we should influence the image of elderly people in the public opinion. We need a stronger emphasis and continued respect for the rights of elderly people. Communication was also something we learned that could be better. There were a lot of misunderstandings during the crisis. There were task forces, there were policymakers who were saying things, there was the media that had a great influence, and we tried to streamline this. What we needed was a unity of command. Also, we often were used by media to sensibilize the population, but also to influence policymakers. So we used media and the media used us. What we learned is that person-centered care is very important. We are evolving towards an ever-increasing diversity of care needs and preferences. There should be a focus on multidimensional biopsychosocial care and needs. The focus on the capabilities of elderly people. And what is very important, because a lot of elderly people died alone, or the staff did not know how they want to die, that we should work further on efforts towards a palliative care culture, advanced care planning, quality of end of life, and also on the well-being of our elderly people. So also we should have some actions to effort the quality of our elderly care. This through further efforts on quality models, quality policy, indicators, and so forth. A very important issue we were confronted with in this crisis was the lack of medical staff, of doctors, especially of the mandate of the coordinating general practitioner in our elderly care. So we should work on it, because elderly care is also the well-being, is the quality of life, but is also a good support of this medical care. This also includes relational care, a continued and enhanced focus on relations and relational care, including what we call trialogue, so the dialogue between the elderly people, his family, and the staff is very important. And we should continue and enhance focus on a participatory culture in and out our elderly care houses. This regards a participation on organization level, on one hand, where all stakeholders, including residents, are valued and asked to contribute and collaborate in the organization, policy, and daily operations of the facility. So this is very important, and this is something we all also learned. We had to do things above the heads of the elderly people and their family. So about long-term care facilities, we think it's very important to continue the policy work on it, but also to improve the quality of it, as I said. There is a need to ensure a balance between protecting care home residents from a virus that could be fatal and protecting the human rights of individuals on psychosocial well-being, to see their families and their loved ones. And that was the most important thing I learned during this crisis. In the beginning, we did not know what was going to happen, so we act just very rationally and forget often about the emotional state of our elderly people, and also about the caregivers who want to give care and who don't want the distance between themselves and the elderly people. There should be a stronger integration of nursing homes within primary care elderly care as an inherent part of primary care, an integrated care as we speak. And so what is very important is the liaison function from the nursing homes with primary care, but also with hospitals. And that should be honored, and that's what we think today is not enough. About innovation, we also learned that a major crisis can bring major innovation. Changes made during a crisis that are beneficial to residents should be secured and continued. The use of IT, digitalization, using hard and software, we've seen it all above. And when the crisis stopped, or when we thought the crisis stopped, we thought also these possibilities disappeared very quick. New technologies tease us to develop new forms of communication, care, and service provision. This is at a time when we are facing an acceleration of an aging society, simultaneous with increasing shortages on the labor market and new trends to which care must respond. And I want to focus more specific about in the palliative care, we have to ensure that residents have access to timely and high quality palliative care. We have to strengthen national and regional policies and guidelines for provision of palliative care in nursing homes and harmonize the financing modalities for palliative care between the relative and the regional level. We also need more knowledge and experience. Training on end-of-life care and palliative care should be promoted. Contracts of collaborating between nursing homes and external palliative care specialists is necessary. Palliative care as a part of the curricula for healthcare staff is needed. On the job training, we need tools and education. So I come to the end of my presentation, and I want to, with our members, so with our nursing homes, we made some recommendations for policymakers, but also for ourselves. What have we seen? That the division of competence wasn't helpful at all. That we have to create a new harmonized funding model for welfare and care that promotes the scaling and empowerment of care organizations. A resolute choice for integrated care networks, supporting cooperation and simplifying structures, providing regulatory clarity, geographic alignment, and smart digitalization is very needed. And last but not least, formulate an adequate response to the search for employees with attractive jobs, innovative and flexible work organization. I thank you.
Thank you very much, Margot, for that very compelling presentation. I think it provided a very good overview of both lived experiences as well as the actual effects of what's going on in residential healthcare in Flanders. I'm opening up the Q&A session. Because of the compelling story, we only have a couple of minutes left, I'm afraid. So for those of you who have a question, feel free to raise your hand or post them in the chat box. If nobody is willing to put themselves out there yet, I will go first. So thank you again. I think these lived experiences and the story you began your presentation with, the directors who are calling you crying on the phone is very interesting and should not be forgotten throughout this whole experience, because now it's good to have a more neutral perspective on the situation. But do you have, I'm wondering as a researcher how we can still include those lived experiences in our hindsight and how we should implement them in future policy decisions. Do you have an insight on that, Margot?
Well, I think it's important that you as researchers also listen to them and what they experience, but it was really emotionally very intensive. And also the directors, but the caregivers, they want us to have a solution for this problem, but they didn't have it. So I think it's also important that they know what they can do, but also what they can't do. And I think that should be also important if you investigate the situations and if you do further research, that you know that we can't solve anything. Also, for example, for the labor problem on this day, they also suffer and they say we can't do this, we can't do that. So we have to recognize what we can do and what we can't do, and what they can do and what they can't do. But it gives a lot of stress, if moral stress, if you can't succeed in what you're educated for, in what you work for. So I think that is an important issue also in this theme.
That's a very good input and a perspective that is often overlooked. So thanks again. Should you have any further questions for Margot, feel free to pose them in the chat box and I will invite her to answer them there. For now, we will go on to our second speaker, which is Professor Sarah Willems. Sarah is an associate professor of equity in healthcare at the University of Ghent, specifically in the Department of Public Health and Primary Care. She's also a chair of an interdisciplinary research consortium on quality and safety Ghent, and this aims to have a more specific societal impact as well as provide evidence-based policy for quality and patient safety. In this presentation, she will give us some insights on the PRECOF study, which is an international project aimed at understanding the organization of care in general practices during COVID. So please, Sarah, you can share your slides and the floor is yours.
Okay, thank you everybody. And thank you for this nice presentation or introduction. And thank you to give me the opportunity to present to you today some results of our PRECOF-19 study. And in this presentation, I will zoom into some of the Belgian results from that study. So just a quick word before I start with some content. What is PRECOF-19? PRECOF-19 is actually a study that started during COVID, the very early days of COVID in Belgium, in Flanders, with some students who could not do their master thesis anymore because of COVID. They could not pursue their data collection. We started with them a very small study, first in Flanders, but very soon we got a lot of interest from other European countries asking us whether they could also use our survey in their countries. And so very quickly, PRECOF-19, which started as a very small project here in Flanders, became the largest study ever performed on the organization of primary care in Europe. So more than 45 research teams from 38 countries were involved in this non-funded study. And I want to emphasize is that we asked, or we applied for several funding, but we always got the answer that primary care was not actually the priority at that time. So we did not receive any funding or very limited funding, and this study was funded actually by the different research institutions involved. So how did PRECOF-19 work? We developed an online survey for GP practices. It was developed at Ghent University, and we also validated it in a pre-study in Flanders. And then we used all kinds of techniques to translate all the questionnaire in all those different languages in a validated way. The data collection took place in the different countries between November 2020 and December 2021. And in Belgium, the data collection was done between December 20 and August 21. In total, more than 5,000 European general practices participated in PRECOF-19. And in Belgium, about 480 participants participated. We are very lucky that we could collaborate with University UCL and the University of Liège, because they were really fantastic partners in the data collection in the Walloon part of Belgium. And then later on, we formed a team to analyze the Belgian data. So pre-COVID-19, as introduced before, wanted to look at how general practices worked and organized themselves when COVID appeared. It's a study where we not only looked at the organization of care, but also at well-being of the care providers. For the sake of the presentation today, I will be focusing on two aspects, being how did we in Belgium acted upon the 6 dimensions of quality of care. So how did we do regarding equity, patient-centeredness, patient safety, effectiveness of care, timeliness and efficiency, and I will present to you some results, very limited because I only have 10 minutes, so we have much more results available. If you're interested, do not hesitate to contact me after the presentation, and then we can certainly share some more results. Secondly, I would like to present to you also the differences in the performance between the 3 Belgian regions, because that's also a really interesting thing to look at. And look at the question how Belgium actually did when we compare ourselves to European countries. Also, they're very, just to give you a flavor of the results that we found, I will give some ideas. If you want more information, please contact me. And then the second part of my presentation, I will dig a bit deeper into one specific aspect, being to what extent did our GP practices actively reach out to vulnerable population groups, those patients of which we know they might have had problems in accessing healthcare. So to come to our findings, how did we do concerning patient-centeredness and equity? We had several questions in our survey asking about indicators that give us an idea about patient-centeredness and equity. One of them is the extent to which general practices actually used their electronic medical record to extract, to identify patients with chronic conditions that needed to be seen but were not consulting. So it's a very important tool that can be used to provide equitable healthcare. And what we saw in Belgium is that only 20% of practices actually used their electronic medical records to extract this kind of list. If we dig into that a bit deeper, what we noticed is that they did this mainly to identify patients with chronic conditions, for example, diabetes patients who didn't turn up, and to a far lesser extent to identify patients with already known problems of mental well-being, patient groups of which we know that during COVID they were extra vulnerable, but so mainly used for chronic conditions. Secondly, and that's a good finding, or that's something very good, is that more than half of the practices actually also actively reached out to vulnerable population groups, and I will come to that in a bit. Also, there, same, quite a lot of practices did this outreaching work. However, they mainly reached out to patients with chronic conditions and far less to patients with mental problems or to families of which they know there was already a problem of domestic violence or a child rearing situation. So that there's certainly a learning point for our Belgian primary care system. Looking at the patient safety and the effectiveness of care, I included here two specific results, being in Belgium, and this was something that we did not expect, is that more than half of the practices reported to us that they experienced important limitations to their practice building or to the infrastructure of their practice, threatening the high quality care or the delivery of high quality care. And so that is quite an important one. So we see that a lot of practices, they did want to reorganize care. They did want to separate patient streams, patients with a possible infection versus patients without a possible infection. But still, they struggled to do that because the practice building simply did not give them this opportunity. And we know that quite some patients were, because of that, were at high risk of getting infected actually in the practice, or even our healthcare workers were at increased risk of getting infected. Also, something that was really striking is that only 57% of the practices actually used a cleaning protocol to clean the practices. The good point is that before COVID, this number was even much, much lower. And COVID actually gave a push to practices, general practices in Belgium to start implementing cleaning protocols. Also, providing a separate doctor bag for infection-related home visits was only done in about 1/3 of the practices, although literature shows us that this is actually a very important measure to take in order to prevent infections. Timeliness of care. In the survey, we asked doctors whether they experienced that patients did not get care in time because of a different range of, or a wide range of factors, and more than 70% of our practices reported delay in care processes in patients who actually needed urgent care. And the reasons for the delayed care were multiple. It could be, it is because patients did not know how to contact their practice, because patients were scared to put additional burden on their doctor, because there was a protocol regarding COVID, which delayed actually the non-COVID care, because doctors misinterpreted some symptoms that were COVID-alike, but actually non-COVID, and so it delayed the process of care for this non-COVID illness. So all kinds of reasons that led to an important delay in care for patients without COVID. What we see is that COVID actually gave a big push to practices to shift tasks. And in a lot of practices, more than 90% of our practices, non-GP staff members were much more involved in the triage of patients, where they did not do that before. In the largely majority of the practices, this was done now. Usually under the supervision, and I must say in almost all practice, under the supervision of a GP. Also giving information and recommendations to patients was done by quite a lot of non-GP staff in practices. So when patients also came to the doctor, what a lot of practices told us or reported is that non-GP staff, for example, the secretary, the nurse, took the patient aside and took a bit of extra time to explain how patients should isolate themselves and how this had to be done. So that was really good in the informing patients. So how do we do when we compare Belgium with these results on a European level? The findings are scattered. For some outcomes, Belgium did really good. For a couple of outcomes, Belgium actually did not good at all. And for a large number of outcomes, we are somewhere in the middle. Again, I did not have the time here to go into details. I just picked up a couple of them that are striking. What we see is that on triage and on how GP practices organized and reorganized their appointment system, Belgium in generally performed well compared to other European countries. However, where we do not score well is the use of triage protocols. It was an important difference between Belgium and a lot of the other European countries. In a lot of other countries, very specific triage protocols were developed that GP practices could use in their practice when patients contacted them for an appointment. In Belgium, that was something, there's certainly a learning point for future pandemics or future crises. Again, here, infrastructural problems, having a separate medical bag available. Also here, Belgium is not doing very well, probably because Belgium still have quite some single-handed practices, usually smaller practices. And so the availability of room, of a larger waiting room, for example, that could be split up in two was less possible than in other countries where there are mainly larger group practices. Belgium actually scored remarkably low, and with that we mean in the lowest quintile of the European countries regarding the timeliness of care for patients with non-COVID. So this is certainly something that needs to be looked into more into detail and see what we can learn from that. So if we compare Belgian regions, we noticed considerable differences between the three Belgian regions. And however, when we looked more into detail into the results, and when we analyzed our data, adjusting for structural practice characteristics, almost all of the differences between the regions disappeared. And the practice characteristics that we included are noted here. For example, the practice type, the size of practices, the payment system, etc. So what we know, this seems to indicate that there are differences between the regions, but the differences are largely can be largely attributed to the fact that the practices are different between the regions. The way we are organized is different between the regions, and this explains why they also perform differently. And our results do not seem to indicate there's a cultural difference in how to deal with crisis between and how to deal with quality of care or patient safety between the regions. There was one persisting difference in between regions, and that was the availability of multilingual communication. It's kind of logic, but in the Brussels capital region, the availability of multilingual communication was much higher than in the Walloon region and in the Flemish region. And it's quite logical, because also the language diversity in our Brussels capital region is of course larger than in the rest of the country. Okay, when we focus on this reaching out to vulnerable patients, we wanted to look more into detail what the practice characteristics are, but also the patient population characteristics are that influence or that have an impact on the level of reaching out. So what we found is that there are some factors that are significantly associated with more outreach work in primary care practices in Belgium. One of them is certainly the size of the practice. When bigger practices, group practices, reach out much more frequently than mono or duo practices or single-handed practices. And of course, and it is also very logical, but we can find it in our numbers, is that having a nurse or a social worker or a health promoter available in the practice makes it much more easy to actively reach out to vulnerable population groups. A very interesting finding from the Prikov study was also that when we look at municipalities with high vulnerability, meaning municipalities, regions where there are a lot of patients or a high proportion of patients with vulnerability, we noticed that it's specific that the outreaching in practices located in those areas is that those practices actually reached out more often to patients with moderate medical complexity compared to low and high medical complexity. So it's clear that reaching out is easier and is done more often for those patients with moderate complexity than for patients with already a very complex medical situation. Apparently for those complex situations, GP practices did not feel well trained, did not have the right protocols, did not know very well how to do that. In case of moderate medical complexity, for example, a patient without any multimorbidity, but with diabetes, for example, it was much easier to reach out because the message was much more simple. And then the patients with low medical complexity, actually very few outreach was done there. Good. Leading to our take-home messages is that Belgian GP practices made very important structural and organizational adjustments to guarantee high-quality patient care. They did a lot. they were very inventive, and they actually succeeded in making changes that contributed to all the dimensions of quality and patient safety. However, we also noticed in our study that they encountered problems in doing so. Secondly, the difference between Belgian regions seem to be attributed to the difference in practice characteristics more than to the cultural differences or the eventual cultural difference between the regions. Thirdly, outreaching work, which is very important when trying to limit the impact of COVID or of a crisis on health inequalities, is facilitated by group practices and by the availability of at least one staff member other than a GP. So having a nurse, a social worker, a health promoter, but even a receptionist in your practice can help and facilitate outreaching work. There, what we see is that outreaching to patients with chronic conditions is done much more frequently than outreaching to patients with mental illness or to patients with, of which is known that there is a situation of family violence or a child rearing situation. This learns us that we actually need to train our GPs better to do this kind of outreaching work. When we want to improve the effectiveness of outreaching efforts, we need to address some organizational factors also in the practice. So learning GP practices to use their electronic medical records good as a tool in population health management, and particularly in practices that are having already a lot of socially vulnerable patient population. They need to be our first target group. And then lastly, we see that we need additional research to look at more in-depth, to get more in-depth insights into the underlying mechanism. How did this actually work? What were the barriers our GP practices were encountering? So this was only a glance on the results that we have in the pre-COVID-19 study. If you want more information, do not hesitate to contact me or to contact Esther van Poel. She's here also. She is our study coordinator. Or please visit our website on the pre-COVID-19 study, where you can also find all the publications that are being written on this database.
Great. Thank you very much, Sarah, for this very interesting presentation. I see we've gone a little bit off our timing schedule, so I will propose that guests that have questions on this presentation to pose them via the chat box. I also see there are some questions for Margot, but unfortunately she had to leave a bit earlier because of another meeting. But I will send her your questions via email and your contact information. So that leads me to go to our next speaker. That is Dr. Johan Pauwels. Johan is currently a physician auditor at the Hospital Audit Unit at RISIF-INAMI, which is the National Institute for Health and Disease Insurance in Belgium. Johan has ample experience in both practical healthcare as well as healthcare management and giving policy advice. And today he will share his findings on the hospital audit. Johan, the floor is yours.
Thank you very much. Good morning, and thank you for the invitation. Okay. Early 2020, the Hospital and Transport Surge Capacity Committee asked us if the reduction of regular hospital care was in accordance with their instructions. And later on, we were also asked to estimate the possible backlogs in regular care. So that's the reason why we started this. Please keep in mind that we made our estimates using incomplete billing data 4 months after prestation through accelerated data streams. Possible data backlogs should be understood as non-performed care against advanced projections. Of course, not all non-performed care can or has to be caught up. We will come back to this later. Here you can see the evolution for a sample of 154 surgical procedures from February 2020 till February this year. The procedures were divided into 3 bundles, one for essential care, represented by the green line, one for non-essential care, red line, and one for mixed care, orange line. We checked how much activity was retained compared to a simulation in which there would be no COVID at all. This baseline is here represented as 100%. Thereby, we took into account the trends in the years before COVID and shifts in bank and school holidays. The blur around the lines represent the confidence interval. During wave 1, we saw a very large drop, minus 94% in non-essential care, so retaining only 6% of the expected activity. This finding is completely in line with the request from the HTSC to stop non-essential care. This was done in order to reserve personal protective equipments and care capacity for COVID patients, as well as for regular patients needing essential procedures. Nevertheless, a significant drop in essential care to 57% was noted. This unwanted side effect was much less pronounced during the second wave, in which, among other things, more PPEs were available. Latest data shows significant catch-up movements, especially of non-essential care, between the COVID waves. However, significant reductions in regular care are still observed during the waves. As a result, the pressure on hospital care remains very high till now. This overview shows the possible accumulated backlogs for surgery. To this end, we selected the top 10 activities per discipline. Large uncertainty margins in some disciplines are due to fluctuations in activity before COVID and/or small numbers involved. The average number of transplantations, for example, was 800 cases a year pre-COVID. Nevertheless, our estimates were in line with an international publication on the topic. Most disciplines had a backlog between 10 to 18% of their expected annual production. This possibly means that they still have to catch this up, but it may also be that the demand for surgical care meanwhile has decreased. The latter may be a consequence of other treatment methods, overcrowded primary care, patients' fear of hospitalization during COVID, the spontaneous disappearance of their complaints, or increased deaths in certain patient categories. Most backlogs are diminishing, for instance, in abdominal, in urological, and in plastic surgery. Recently, we see a small increase in the backlog for thoracic surgery. Nose, throat, and ear surgery, as well as vascular surgery, have very high but declining backlogs. This was comparable to findings in the Netherlands and is partially explained by overuse in the past. We see a stagnation in gynecological surgery and in transplantations. Due to recent changes in billing codes, we have, however, also artifacts, and this is, for instance, the case in neurosurgery and in orthopedics. If we filter those artifacts out, we get the dotted lines. As mentioned before, not all potential backlogs are real backlogs. This is why each top 10 intervention was also analyzed separately, so policymakers and medical specialists can draw specific conclusions. In order to evaluate a possible link between the backlog for a procedure and overcrowded intensive care services, we give the extent to which the procedure required intensive care admission in pre-COVID times. We will only go over the most important findings. Looking at the details, the insights have remained largely the same over the last 7 reports. We see significant backlogs, both in terms of volume as in possible impact on quality of life and or life expectancy for several open heart surgeries, heart transplants, heart-lung transplants, hemicolectomies, and total colectomies. The backlogs for kidney transplants, carotid artery revascularizations, and cataract surgery have recently dropped below 20% and therefore are crossed out here. As far as transplantations are concerned, the backlog is of course also influenced by the number of available donors. The second finding are large backlogs in interventions that we should do less because they are known for overuse. It's good to note that the indication and priority settings were strictly applied, generally speaking. This is in line with the directions of the HTSC committee. Some examples are shown here. The catch-up with an overcorrection for gastric bypass, although partly due to a decrease in other obesity procedures, remains a medical prioritization concern. Oncological procedures have generally been well preserved. The following overview is about 6 internal disciplines. Very good news is the recently cleared backlog in cardiology. And another good news is that we don't see any backlogs for oncology. On the contrary, we see more than 20% additional activity. This can be partly explained by the fact that many therapy schedules were adjusted during COVID. But since the margin of uncertainty is quite large, it remains a conditional finding. However, most of our estimates are in line with the data of the Belgian Cancer Registry. We also see further declines in backlogs for gastroenterology and a stagnation for neurology. Points of attention are the still increasing backlogs in pneumology and in geriatrics. Both disciplines saw many COVID patients and they can be overloaded as a result. There may be also substantial excess mortality in their patient population, and for pneumology, avoidance of aerosol-generating procedures is another factor possibly involved. If we look at the details, the points of attention include still important backlogs in gastroenterology for ileoscopy with biopsy, total colonoscopy with biopsy, and endoscopy of rectum and sigmoid. For pneumology, bronchoscopies with biopsy have backlogs between 24 till 39%. So these findings may have, of course, an impact on cancer diagnosis and follow-up. For oncology, there is a significant backlog regarding allogenic bone marrow transplantations. And more recently, we also see fewer autologous bone marrow transplantations. However, the confidence interval is wide. Finally, we looked at psychiatric care. The cumulative backlog is 11%, both in general as in psychiatric hospitals. For adult psychiatry, the backlog for supervision fees has largely stagnated. For child psychiatry, the backlog due to COVID has disappeared in psychiatric hospitals and almost disappeared in general hospitals. This doesn't mean, however, that existing waiting lists could not have grown. But we have no insights into those waiting lists. This in contrast to the public Dutch monitor for the accessibility of care, which clearly indicated that there were more referrals from primary care. Another point of attention is the growing backlog of psychiatric consultations at the request of the treating physicians in general hospitals. So based on the many problems we encountered in extracting some useful policy information from the large amount of data, we provide our recommendations. We propose to realize real-time overviews, therefore fast-track data transfers are needed, and also a current picture on effective operational beds. Streamlining of processes is also recommended, which requires uniform criteria for admission and discharge, supporting automation, uniform rules for the deregistration of operational beds, and fast and detailed views of patient transfers between hospitals. Monitoring outcome, which includes accessibility of care as well as complication and mortality follow-up, is the third recommendation. The fourth being administrative adjustments, as there are actual criteria for pediatric intensive care units and intensive care units beds, a view on campus level, and adjusted financial mechanisms for justified and operational ICU beds. For all details, you can see our reports. We would like to thank all physicians and healthcare staff for the extraordinary efforts they make. Thank you very much.
Great. Thank you, Johan. I think your presentation gives a very clear overview of the pressure points in the hospital care system. So thank you very much. Again, due to time constraints, I'm afraid I have to invite the guests to pose their questions via the chat box and invite you to answer them there. And that leads me to our final speaker to give the closing remarks. I present you Pedro Facon. Pedro is currently Deputy Administrator General at RISIF INAMI. He previously was the Government Commissioner for COVID-19, and he has ample expertise in both research, policy advice, and healthcare management. Pedro, the floor is yours.
Thank you. And first of all, I would like to thank Cienzano for organizing this evaluation moment, and Margot, Sarah, and Johan for the presentations they gave, and that were, as always, very interesting. And as Margot said in her presentation, there's a kind of sentiment that everyone wants to forget what happened during COVID, but it's really absolutely necessary that we evaluate what happened during that period, also in the healthcare sector, which was the focus of today. And we need to evaluate at different moments. We have been evaluating during the crisis, the installation of the commissariat, and the strengthening of crisis management was one of the effects of that, which has also had a positive impact. If you look at the cumulative excess mortality, it's clear that it was mostly during the first wave that Belgium was hit very hard, and afterwards we kind of caught up a little bit with international trends. We did some evaluations immediately after the crisis, but we also need to take some distance from what happened. And for example, now we are almost a year from the most acute phases of the crisis, and it's good that we are still evaluating. And there have been so many initiatives, and I want to stress that because we often hear that we are not open enough to evaluation. But I remember that when I was the president of the Hospital and Transport Search Capacity Committee, we asked the KCE to evaluate our works, which has resulted in a report. We had the audits of which Johan has presented now. KCE is also doing studies on the reorganization of ICU care. Evaluations are still going on testing and on the way we use the federal platform and the classic laboratories. We have had audits from the Supreme Audit Institution, Rekenhof, Cour des Comptes. We have had political evaluations in the parliaments. We have the evaluation that the OECD is doing, and that will result in a report by the end of this year. Interior Affairs has been evaluating crisis management. So I do not agree with the fact that we would not be open enough and that it's only a small group of people that is evaluating. I think there are a lot of actors that are evaluating, and it's also necessary. Of course, what did we learn? What did we do in the meanwhile? I think that a series of things are going on with regard to strengthening preparedness with regard to health emergencies. And we've seen some positive effects during the crisis of COVID, but also when we had the issue of the monkeypox. We've already seen that the way we respond to things are more swift, even if there are still a lot of problems before us. The problem of data is still something that is clearly something we need to work on. We've heard it during the presentations, but it has been something we struggled with all along the crisis. We really need to have more real-time data and insightful data to steer policies and to adapt practices. With regard to infection and preventive control, last week I was in Leuven, where I got an overview of what is happening around the host pilots we have been launching, and I'm really very proud of it. So this was a way of valorizing all the expertise with regard to infection and prevention control, to the first line, to primary care, but also to nursing homes. And we really do see effects of that. They are rolling out a series of activities, and this is really very positive. With regard to innovative labor organization, I think we've done good things during COVID, but I also feel that after COVID now we are seeing again a lot of corporatist reactions, and we really need to exploit all the capacities available. We are not doing this enough yet, even if there are some progresses, but I think we can do better, and this is something we need to continue to work on, also in a structural way, not only in pilots or in temporary projects. Everything that has to do with online care, we've had some innovations during COVID, and they need to be anchored now. Some steps have been taken. Mental health care remains a very important topic where the rollout of policies and budgets that have been liberated, yeah, they are there, but the practice is not following as quickly as the budgets and the policies. Let's be very honest with respect to that. Also, the mental health care of our professionals themselves. We have been investing in projects like Doctors for Doctors and Arts in Nood. But we really need to continue and to scale up all this. Black holes I see where we really need to step up because I feel there is not enough action being taken. It's regard to prevention, which is not only a responsibility of federated entities, it's something that we need to tackle together. I think that during the crisis, but also after crisis, we didn't act enough on risk factors. It was a missed opportunity, and it's still something that is very hard to tackle in this country. With regard to population screening, when I see in the presentation of Sarah that 20% of the GPs that were in the study extracted a list with people with chronic conditions and 50% of outreach toward more vulnerable people. This is of course not bad, but we could do much better, and the deployment of population screening at the level of the GP practice, but also at the level of the primary care zones or whatever it is called in the different federated entities, is something that we really need to develop and we need to invest in. This has also an obvious link to everything that has to do with data. And I also think that the way we organize our healthcare system, the use of triage, of protocols, etc., we did some things during COVID, but we could do better and to try to have more, more reasonable and efficient care organization. This is something that is a continued point of attention. So, to say all this, I think we see real progress, but we need to continue to be very attentive and to continue our efforts. We need to install a real learning culture where we act fast, fail fast, and then adapt policies. And we will also need to continue investing in healthcare. There is pressure on government budgets, obviously, but as OECD has been saying, and OECD is not a leftist think tank, it's really a moderated organization with social partners to augment, to increase the resilience of the healthcare system. On average, the OECD countries need to invest about 1.4% of their GDP in the healthcare sector, and this will also be important in discussions in Belgium. So just a quick overview on how I look at these things, but thanks again to Cienzano to keep us awake, to keep everyone awake, and to continue these evaluations. And I think 1 year ahead, we should do this again and see how we did progress on all these topics that were mentioned today.
Yes, perfect. Thanks a lot, Pedro, and we'll indeed take note of that and follow up on that good suggestion. If you would still have 2 minutes, I see that there is a question in the chat from Patricia van Pelt, who's involved in the prevention platform. So she's asking if during the review there will be room to look at the prevention perspective. As you already mentioned, Pedro, shouldn't we pay more attention to lifestyle factors from a healthcare perspective as one of the ways to cope with future crises? So will this be included? And I believe she's referring to the OECD review. So would that be one of the points that will be considered there?
Yeah, I do agree. So as said, well, during COVID, it was a lot. If we would have worked more on obesity, for example, and on chronic care conditions, we would have had better results. If we would have known in February, March 2020 that we should work more on it, we could still have launched a program with so many actors in society to do better. And here for COVID, it was a lot on obesity, for example. But maybe tomorrow it will be something else. And we know that with regard to risk factors, doing sports, healthy eating, tackling smoking, tackling also excessive alcohol use. These are all things where we can do better. We are not doing, if we look at the OECD averages, we are often a little bit better than the OECD average, but we shouldn't be content with that. We could do better. We could really do better, and it would be really engaging for society. It's also health should be more about public health, and this also means including the public in our policies and in what can be done. And it shouldn't only be about health care and about health insurance. So it's really an opportunity that is open and that doesn't need to cost always a lot of money.
Yes, thanks for your reply. I see that we have no further questions. We're also a bit over time, so I suggest we conclude the webinar here. So I want to end by thanking our speakers once again. So thank you very much, Pedro, Johan, Sarah, and Margot. Thanks also to Laura for helping moderate the discussions. And thanks to all the people participating to this webinar. As mentioned, the slides and the recording will become available later on, and please don't hesitate to keep an eye on our website or social media to know what the next webinar will be about. Or if you would have suggestions for next webinar topics, feel free to let us know. So thanks everyone, enjoy your lunch break, and we look forward to reconnecting at one of our future events. Thank you.
Thanks, bye.
Bye.
Bye.